Good morning, everyone. Welcome to Pediatric Grand Rounds. Today, if you're in the building, we are not in the Mill Mountain Conference Room. We are in the River Room upstairs on the second floor. 2717, behind Dental. Please join us if you're here. Today's speaker is Dr. Yasaman Brown, formerly Mosadat. She's a third-year pediatric resident here at Carilion. She's from Northern Virginia and has lived here with her husband and fur babies. I'm not going to ask how many. She attended medical school at Kentucky College of Osteopathic Medicine. She discovered a huge love for critical care during her residency, which was encouraged and fostered by our awesome intensivist. She's headed to the PICU Fellowship in Delaware. During her time here at Carilion, she lent her time to multiple committees, GME, Code Blue, and was the recruitment chair for social media. She also completed her QI activity in unplanned extubations and presented her work at the National QI Conference in Denver in 2022. Her advisor for this is Dr. Rahul Pandey. Please join me in welcoming Dr. Yasaman Brown.
Good morning, everyone. So today the topic is going to be an intro to ECMO. I figured that this would be a cool topic to talk about, especially since we don't get a ton of exposure, but we're often sending kids out to an ECMO center when we're stuck in a hard place, and that's what they need. So this will be a brief review for that. Our outline today, so very basic, what is ECMO? We'll start there. Then we're going to talk about the history of ECMO, the indications and contraindications for the use of ECMO, ECMO terminology, monitoring while on ECMO, complications, and most importantly, one of the things that we're going to talk about is implications for the general pediatrician. I know I'm crazy and I love ICU, and a lot of my cohorts are going to be amazing outpatient pediatricians, and so I wanted this to be relatable for them as well, right? All right, so we'll start real basic. What is ECMO? So extracorporeal life support. This is just a general term that is essentially describing support for the failing heart or lungs through mechanical devices that provide blood flow, gas exchange, or both outside of the body. ECMO is the use of at least one membrane lung, blood pump, and vascular cannula to provide blood oxygenation and ventilation. We're going to talk about all of those terms in detail in a little bit. Venous ECMO, so VV ECMO, that's extracorporeal support delivered by drawing blood from the venous system and providing gas exchange, and then returning back to the venous system, which again we'll talk about. And then veno-arterial ECMO is by drawing blood from the venous system, providing gas exchange, and delivering back to the arterial system, bypassing the heart. So just to start, this is just a brief picture. There'll be many more, but this is a very simplified version of the circuit. This is a VA ECMO circuit here. And then, oh, well, you guys can't see me point, but and a VV ECMO above, and it's just the very, very simplified version. As we go through this PowerPoint, we're going to build more and more pieces on top of it. I'm not going to describe each piece here because we'll have that all coming up, okay? So what are our goals of ECMO? Our kiddos can't live, or anybody on ECMO can't live on ECMO forever. This isn't a thing that is a solution. The primary goal is to provide oxygenated and ventilated blood to the body, performing the work of the lungs in VV ECMO, or both the lungs and the heart in VA ECMO. This is just a temporary measure. So this is just to allow the body to heal, or as a bridge to transplantation. ECMO is not a therapy or a treatment, but rather a supportive measure for definitive therapy that you would want down the line. So we're going to talk a little bit about the history of ECMO, which I thought was fascinating. All right, so this is starting from 1971 in the first use of ECMO in an adult patient. I'll mention it kind of bridged off from the 1950s when bypass was first introduced. And then in 1971, they had an adult who was in a motorcycle accident, and he was very, very sick. And it was like, let's just keep him on this bypass and see if it'll work out. Unfortunately, he died, but he lived a while on the ECMO, which was promising and pushed for further research. So just a year later, the first successful clinical use of ECMO in an adult happened. And then a couple years later was the first use of ECMO in a neonate, baby Esperanza. So she was a baby that had meconium aspiration. And essentially the doctors were like, we can't do anything further at this point, unless you want us to try this. So in times of great need, there's a lot of growth that happens. And that's a picture of her at the bottom. They did cannulate her and she did survive. The picture next to it is her with one of the doctors that pushed for this later as an adult. So I thought that was really cool. In 1975, the NIH performs a multi-center randomized clinical trial of ECMO, which went awful, and research just paused. They're like, nope, we got lucky, we're not gonna do it again, for the next 15 years, essentially. There was little research here and there, but nothing multi-center or large. And then in 1976, which this I thought was fascinating, there was a case series of 9 neonates on ECMO, and 3 survived, 33% survival rate, and that kind of opened the doors back up for this research. I thought that was especially cool being that we're in peds, because I feel like the peds world kind of pushed this forward with this. After that, in 1982, another case series of ECMO in the neonatal population, this time with 45 patients and a 55% survival rate. So even better, even more promising. 1984 survival rate of neonatal ECMO increased 70 to 90% at that time. And then 1989, ESLO is founded. So that is something that we'll talk about towards the end of this presentation, but it's essentially an organization that keeps track of everything ECMO. And it's really, really cool. That's why I wanted to have its own slide. So 2009 H1N1 epidemic reveals a 71% survival rate in patients failing conventional therapy for ARDS. And that is where the Caesar trial came from and was published in the UK. So again, in times of kind of desperate need, it pushes this research forward and allows for a gate to open and things that were kind of dismissed because we didn't have any other options for these people. All right, so now that we talked a little bit about the history of ECMO, let's talk about the indications and contraindications, because you're not going to put every single kid, we're talking kids here because we're peds, or every single adult on ECMO. They're not going to qualify, unfortunately. It is a huge, huge, massive undertaking, and there's a lot that goes into it, so we'll get into that. So consideration at all to be talking about it is when the risk of mortality reaches at least 50%. In their current clinical state. It's strongly indicated when mortality continues to rise, as you would expect, to 80% with conventional therapy. And then earlier consideration has been kind of talked about and done to minimize barotrauma and other morbidities from aggressive conventional therapy. So when are we going to do more harm keeping this kid on this ventilator and this epi and doing this rather than going ahead and cannulating them onto ECMO? So I thought this was a great chart to kind of talk about that. These are just the indications. So these are not everyone, but several of the uses of ECMO that are often. So heart failure in its own category, failure to wean from cardiopulmonary bypass, myocarditis, cardiomyopathy, as a bridge to recovery if the heart is going to recover, or a bridge to transplant. Sepsis with profound cardiac depression, refractory arrhythmias, or coronary ischemia if surgical treatment is an option later on. ECMO is not going to be an option if you don't have an ultimate solution, is kind of the key here. Pulmonary failure, bridge to transplant. So if you need a double lung transplant and there's a chance for that and you're a healthy candidate otherwise, then this can be considered. Neonatal respiratory distress syndrome, adult respiratory distress syndrome, persistent pulmonary hypertension, meconium aspiration, like baby Esperanza, pneumonia, of course, and then air leak syndrome. Cardiac arrest from any cause can be a reason to go on to ECMO, although I will say those kiddos definitely have a more poor outcome, even from being cannulated. And then transplantation. So as a palliative effort to get to transplant, and then there's just a couple other things, special circumstances, special surgeries that could also qualify you. Contraindications. So this was a really important point that I wanted to bring up. ECMO is great, but there are significant contraindications. So if you have end-stage disease and you don't have anywhere to go from here, that's not something that they're going to undertake at that point because it will do more harm. Untreatable underlying disease, congenital malformations, that is a point of discussion, especially in the pediatric world. So there have been multiple studies of intensivists, neos, et cetera, of what are we going to do with our kiddo that has CP, our kiddo that has this genetic issue, et cetera. Are we going to offer ECMO? These are the ones who are going to get sick, as a generalized statement. Are we going to give them this? Is their quality of life going to be better for it? And there's significant variability. It's nothing that's, okay, everyone with this set of issues is going to get cannulated and this set of issues is just not. It's totally variable on the team that's taking care of the patient. Significant neurological impairment and genetic abnormalities. So they point out trisomy 13 and 18. That's why the bullet point before it, it's kind of all the other congenital issues that you can think of as well. It's kind of encompassing both. Severe irreversible organ dysfunction. So unless you're a candidate for transplant or an organ that can recover, then that is going to exclude you. Extreme prematurity, so gestational age under 35, and then severe coagulopathy or contraindication for anticoagulation. So that's huge, and we're going to talk a lot about anticoagulation here in a little bit. So as with anything, we weigh the benefit against the risk. Threshold for initiating ECMO is not established for pediatric acute respiratory distress syndrome or acute respiratory failure. So this is kind of what I was hinting at in the last slide with there's tons of variability, but even in a kid that is a candidate for ECMO, there is still variability of when we're going to pull that trigger. The progression to ECMO from invasive mechanical ventilation is undertaken when clinicians believe the risk of progressive ventilator-induced injury, and multiple organ dysfunction syndrome or life-threatening hypoxemia outweighs the risk of bleeding, thrombosis, and other potential complications. So it's a huge discussion, and it's definitely not taken lightly. When does this transition occur? So again, tons of variability. There's no exact answer. If this kid has this marker, oh, straight to ECMO. If this happens, okay, go ahead and cannulate them. So they have actually been studying this. Observational studies have found that the transition occurs when at least two criteria are met, or one of these two criteria are met. One of them is an oxygenation index of approximately 40. We're not going to go into the math and all, it's 7 a.m., but the equation is right there, and it's actually really not that complicated. You take the FiO2 just from your ventilator that's sitting right there, the mean airway pressure times 100 over the postductal PaO2. And then you can see at the bottom, there's like a range of mild, moderate, severe, very severe being at 40. And then another thing to look at is the partial pressure of arterial oxygen to the fraction of inspired oxygen. I can say that when I was at an ECMO center last year, we used the oxygenation index to pull the trigger for ECMO for one of our kiddos. And it was right about that 40 number. So this is, again, another randomized trial to kind of say, hey, what are we doing with these kids? When are we saying, all right, let's do it, let's not? This includes adults, but just to talk about the neonates, the UK neonatal trial found that oxygenation index of greater than 40, again, or PaCO2, so significant hypercapnia greater than 90 for greater than 3 hours was something that was met on these patients. Duration of mechanical ventilation with less than 10 days of high pressure ventilation, And I think that that's important to note because after 10 days, what irreversible damage do the lungs have at that point, and are they going to be a candidate still? And then age less than 28 days. This was just a part of this trial specifically. And then exclusion under 35 weeks or under 2 grams or 2 kilograms of birth weight. So I'm not going to get into the other side of it because that's adults, but I thought that was interesting as well. So I briefly touched on VV versus VA ECMO, and choosing between them is a whole other battle. So VV and VA ECMO, the choice should happen depending on what the patient needs, what level of support they need at the time of cannulation specifically. So you're not going to put a kid on VA ECMO because maybe their heart's going to fail, or maybe the pressors are going to continue to go up. If they have minimal to modest needs for pressors or inotropic support, then it's always worthwhile just start with VV ECMO first. There's a whole host of complications that comes with VA ECMO that may not always be seen with VV. And then you can always escalate. If you see that the heart is not progressing the way that you wanted to, it's having some issues, then you can transition. In some situations, there are some hemodynamic instabilities saying VA ECMO is necessary, but then after some improvement, you can always back step back to VV. So just to drive this home, the point home, VA ECMO provides hemodynamic support. That's just the key there. You will see though for these kiddos or these patients that their pulse pressure and MAPs are actually going to be lower than usual, but systemic perfusion is usually what they need, where they need it to be. And then inotropes and vasopressors will try to be weaned off if you're using VA. So what happens next? You've determined, okay, we are thinking about ECMO. It's a consideration for this kid. They're a candidate. What do we do? So assess is the first one. That's the step that we're at. Patient candidacy for ECMO, reversible cause of cardiopulmonary compromise, cardiac and vascular anatomy and patency. So, all right, they're a candidate. We get the team together, alert the cardiac surgical team, surgeons, nurses, and a perfusionist, assign roles, including the team leader, and then notify the blood bank. These kids will inevitably be getting lots of blood products during this process. And then pre-cannulation, confirm that you have vascular access. That's huge, usually a central line and an art line at least. Central line so that you can give whatever that you need to give to them. So whether that's pressors, fluid, bloods, and then an art line so you can continue to monitor their pressures, their blood pressures throughout this process while they're getting cannulated. And then, of course, you prepare all those things, prepare for surgery, and then you talk about the cannulation strategy. So especially in pediatrics, this is huge. So one, you don't want to compromise them for the rest of their life if this is going to be a high-risk kid for needing cannulation again. So doing a cut down of a particular vessel that you might need is not going to be a great idea. So you want to use particular vessels that you're going to find that probably won't be used again, or sometimes they'll just go to open heart ECMO, essentially where they cut the chest open. And so those are things to talk about. The sizes in pediatrics are also a challenge. So if you have a tiny neonate and you're trying to put a cannula in there to literally put all of their blood into a machine and return it, while still perfusing their tissues, trying to get them to heal, those vessels are not a lot of options. They're a lot smaller for the cannulas that are available right now. And then post-cannulation, so you want to image to confirm where this cannula is. And then you also want to evaluate the ventricle decompression at that point, the adequacy of support. So you want to continue to do really, really frequent vitals, labs, et cetera. And then blood product replacement and ongoing anticoagulation, which we'll talk all about in a minute. So just for the basics, once the decision is made to initiate ECMO, a large vascular cannula is placed in the central vein. The vascular cannula is attached via tubing to a blood pump. The blood pump generates negative pressure to pull the blood. which extracts it from the venous blood in the body. And then the blood pump propels the venous blood into a membrane lung. And the membrane lung functions to oxygenate this blood and remove carbon dioxide. We'll talk about that more too. Are we dead? There we go. So, ECMO terminology. Starting to touch on it, let's get into it. So these are the big important things in ECMO. I didn't go into every single detail. I just wanted, if any of our residents or med students, anyone is ever in a situation where you have a kid on ECMO, a family, et cetera, and you hear these words, to have a level of familiarization with it. So one of the first things that's super important in ECMO is sweep gas. This is the gas delivered to the membrane lung. Oxygen or a blend of oxygen, rarely with carbon dioxide, because the whole point of the sweep gas and the manipulation of it is to wipe out carbon dioxide. So it's essentially your ventilatory support, okay? Vascular cannulation, which we talked about, so the placement of a cannula. You can have a single lumen cannula, not super common, with 1 lumen for blood drainage or return to the body, and then a dual lumen cannula, so a cannula with 2 lumens, 1 for blood drainage, 1 for blood return. And then you have the ECMO blood flow rate. That's the volume of blood expressed in liters passing through an ECMO circuit in a minute, and that's really important. We'll talk about that. So ECMO circuit is the overall circuit that you're looking at, the tubing, the devices, the blood pump, the membrane lung, and it starts at the cannula withdrawing the blood with that negative pressure and ending with the blood returning to the patient. There's a bladder in the ECMO circuit. This is a 30 to 50 ml reservoir. This is actually a very cool and sophisticated piece of the circuit that we won't get very deep into because it is a little bit more complicated, but it's usually the lowest part of the circuit, serves as an air trap to relieve pressure and an access point to remove any air that's been collected within the circuit. It's also a shock absorber, so the blood that drains into the bladder is gravity dependent and then gets drawn actively into the ECMO pump. If the pressure gets too high, the bladder will collapse on itself, which we'll get into here in a picture or so. And then it tells the pump, all right, you need to chill out. This is going too fast. The pressure is too high in the body. And then the pump, of course, the main piece, mechanism for drawing the blood into the circuit, then back into the patient. Usually these are roller pumps with positive displacement of blood, although newer centrifugal pumps are being used more frequently. So I'll say the centrifugal pumps are the ones that I saw. There were like compressor pumps as well, but they cause a lot of hemolysis. So that's not really being used anymore. And these are just all mechanisms of being able to move that blood through the body. A little bit more terminology. So of course you have an oxygenator, which is just the separate piece that oxygenates the incoming blood with hollow fibers and a countercurrent exchange. That is typically set to like greater than 350 parts oxygen, and it also removes CO2, so huge. There's a heat exchanger. So this was an interesting thing. This is used to maintain the temperature of the blood. You can't tell if these kids have fevers, if they're septic, if they're getting worse, because their temperature is completely controlled by an outside source at this point. Venous saturation monitor, so you're looking at the oxygen saturation of the venous drainage to see how well your ECMO is working and how hungry the body is at that point once this blood is going oxygenated into the body and coming back out, how much of that oxygen is taken out. And then that can also give you an indication if recirculation is happening. So this was a huge issue that I didn't talk a lot about in this, but at times if you have a dual lumen cannula like in the IJ and that's where you're going through, it's a small space, it's now in the atrium and in the heart, sometimes the blood that you are returning to the body that's oxygenated can get right back into the ECMO circuit without hitting the body. So then they're getting oxygenated again and the body is not seeing that oxygenated blood. It's recircling into the cannula, and that's something that you really have to watch out for. And then another cool thing is ECMO does offer the opportunity to put these kiddos on CRRT or plasma exchange. So if they need kidney support as well, that's another thing that you can incorporate into your system rather than having to do a whole other system. So this is a picture of ECMO. This is pretty typical. You of course have like this stuff in the background, which is your ventilator, your monitors, etc. But then this in the very forefront is the display monitor for the ECMO system. You have the blender and gas sweep where your ventilation is primarily happening. Your pump console, which displays all of the information about your pump. Your centrifugal pump itself in that middle, if you can see it, it's actually quite small compared to what you would think. You have your oxygenator, heat exchanger, and then your circuit as well. So this is fascinating and also terrifying if you walk into your patient's room and all of a sudden this huge apparatus is there and you're like, whoa, what has happened? And this is with the many other pumps you can see in the background, a ventilator that will be in the room, and more monitoring devices. So this is a little bit more, I don't know if you guys remember that initial picture that I showed. So this is kind of building on that. So there's several access points within this circuit, and that's really all I wanted to show. These access points can be used for flushes for the system. It can be used to test the blood. It can be used to give certain medications within the system. And I thought that was pretty interesting to point out. So you have like a venous sample area, you have a heparin infusion port, you have a venous sat sensor, which we talked about, an arterial blood gas sensor, and several other points of access within your system that you can use to manipulate while your patient is on there. So we touched on this briefly, but again, it's really important in this system is sweep. That's the principal determinant of carbon dioxide removal during ECMO, and that's the rate of sweep gas flow. So I was talking to one of my co-residents, Amin, and he was like, you're sweeping the carbon dioxide away, sweep. And I was like, all right, it was great. And that kind of sticks in there. The faster the sweep gas moves through the membrane lung, the greater the diffusion gradient, the more carbon dioxide is removed from the blood. ECMO oxygenation, that's almost entirely determined by the amount of oxygen that can bound to hemoglobin, of course. And in that, the higher the ECMO blood flow rate, the more deoxygenated hemoglobin that is withdrawn from the body and is made available for the device for the oxygen uptake. So this chart is kind of tiny, but you can see for neonates, your oxygen delivery is 6 mLs per kg per minute. And that's 100 to 150 mLs per kg per minute in the ECMO blood flow rate. So those are the settings that you will put based on the size of your patient. And then of course, as you would expect, it's a little bit less. For a bigger kid, the neonate's hearts are pumping fast, moving. For children, it'll be 4 to 5 mLs per kg per minute, and then 80 to 120 mLs per kg per minute through the circuit. This is terrifying, but it's an incorporation of every single thing that we've talked about. That's why I included this picture. I'm not going to go through all of it again and do a pop quiz at the end with the fill-in, but essentially I think this picture does a really good job of summing up every single piece that we've talked about. And then it starts to get into some of the other stuff that we're going to talk about here in a second, including anticoagulation. All right, so monitoring while on ECMO. So this kiddo, this patient is on this huge apparatus. Are they gonna have a nurse and an attending and a resident? And that's it? No, they're gonna have lots of people at their bedside 24/7. So we'll talk about who is gonna be on that team. So they'll have a large team. They will have 2 RNs. One of them is gonna be the ECMO RN, just committed to managing that ECMO system. Then you'll have a bedside RN. You'll have an attending that's trained in ECMO. So they've done an extra year or so of just ECMO training. It depends on what their field is. And then you'll have a PICU attending as well. This can be the same person, but if the PICU attending is not someone that does ECMO or has had that learning or that additional year, then they're not going to be the same person. You'll have two different people. So some days when I was at Nemours doing ECMO on this, or being a part of a patient who had been on ECMO, we had an attending that actually came down from the NICU if the attending that was on for the day wasn't someone that was well-trained in ECMO. And when I say well-trained, that's beyond the scope of being in fellowship for 3 years and pick you after the 3 years that you've done in residency, et cetera, et cetera. This is an additional year or change of just dedicated ECMO learning. And then you have a medical student, resident, and fellow. And typically, from what I saw on those rounds, you will also have the cardiac surgeon that has cannulated them touch base, especially in the early phases. So once you just, in the first week or so of being cannulated, there's gonna be a lot of moving pieces. Is this cannula the right fit? Is it in the right location? And all of that is gonna be really critical to the patient. So could be a little bit confusing of what is the ECMO nurse supposed to do and what is the bedside nurse gonna do. This is just a quick review of it. So the ECMO nurse is really well trained in this, is used to families who've had kiddos on ECMO, which is extremely distressing. And so they're gonna give that support, give that expertise. They're gonna continue to monitor the ECMO circuit. They're gonna watch the ECMO flow, sweep gas, oxygenation. They're gonna monitor the anticoagulation management as well. So when we would present on rounds, we would stop at the anticoagulation, and the ECMO nurse, now this is just where I was, it might be different elsewhere, would start presenting all of the findings in terms of anticoagulation. Management of the heparin infusion, administration of blood products, hemofiltration, and emergency measures troubleshooting the ECMO circuit until the perfusionist comes in. Responsibilities of the bedside nurse, so all the rest of it. So basic care, IV fluids, medical therapy, if they're getting feeds, vitals, monitoring fluid intake and output, essentially anything that you would imagine our nurses do here, they're also doing, because that doesn't just go away when they're on ECMO. There's still a patient there that is gonna get bed sores if they're not moving, that is gonna have issues, that is having urine output, is doing this, is doing that, and you have to manage that side of it too. So we're talking about monitoring. This is a huge piece. When we had that kid on ECMO, I think I saw the echo tech in that room more often than I saw them anywhere else. They pretty much live there. And that's because it's an essential tool for monitoring the patient while on ECMO. What that's gonna do is look at real time where that cannula is, the filling of the left ventricle and the ventricular function. And then once they've been cannulated, they're gonna continue to monitor them, troubleshoot, look at if there's any recirculation like we talked about, look at the myocardial recovery, how is the heart functioning, is it angry that there's a cannula stuck in it, is it gonna recover, and that's huge. Some of the complications that I just told you about, so the cannula itself, the anticoagulation, so are there clots forming around that cannula? That's also a big deal. Pericardial effusion, is that an issue that you're seeing now around the heart? And then of course tamponade can happen from an effusion, formation of thrombus, which we talked about too. So big, scariest topic in ECMO, in my opinion, is the anticoagulation. This is the area that you can have a ton of complications, things can go wrong. This is the huge, huge tipping point for a lot of patients. So anytime you take blood out of a patient, how many times do we have lab calling us saying, your sample's clotted, sorry, we can't run it, because it's out of the patient in a tube. Blood is not gonna do that without clotting. So imagine pulling the entire blood volume or a large portion of blood from a patient and putting it into an external circuit. It's gonna be coagulopathic. It's gonna clot, and it needs to be anticoagulated. So unfractionated heparin is the predominant anticoagulation agent for this. The circuit itself might have citrate in it as well, so you can have multiple anticoagulation agents working, some that can't be in the body and some that are okay to be in the body. But heparin is the main one I want to focus on. It binds to antithrombin to potentiate the effect to inhibit thrombin 1,000 to 2,000 fold. While on anticoagulation, this helps prevent the thromboembolic complications and it inadvertently places the patient at risk of bleeding. So around 70% of pediatric ECMO patients will have bleeding as a complication. That is a huge number, and it determines how they will do once they come off ECMO, depending on where that bleed is. So needless to say, it's very complicated. It is not just complicated because you're trying to manage an entire cascade of anticoagulation within a patient, but it's also complicated because you're doing that against a couple other things, like age-related developmental hemostatic changes. The variable effects of being critically ill will also cause issues with coagulation. So how many times have we had kids that go into DIC because they're extremely septic, or have a severe trauma? So that's a huge issue. And then of course, like I talked about, the blood circuit interaction. A significant bleeding, you will have to intervene. Surgical intervention is a possibility, which is tough. And then there are certain infusions that you can give. Topical thrombin, 7, and then running the circuit briefly without heparin, which is probably the most common thing I've seen, and it makes everyone anxious, but it's an option to kind of help the body readjust if they're extremely coagulopathic. So another big thing is platelets are kept at greater than 100K to avoid significant bleeding. Sometimes 50 is accepted. Heparin-induced thrombocytopenia can occur 5 to 15 days after initial exposure. This requires transition to a different anticoagulation agent, of course. TEG is used at some places to help guide your anticoagulation methods regarding the clotting cascade and anticoagulation. I think I have a picture of that coming up too. And that's a whole other thing that can be real complicated. Anticoagulation, so the reduced ability of heparin to inhibit thrombin and fibrin can be termed as heparin resistance. That's yet another complication that you might see in this system. Heparin resistance is recognized when you're needing more and more heparin to anticoagulate this kid. And it's definitely a concern for patients because on ECMO, the antithrombin activity is decreased anyway. And then to add to that, neonates have developmentally lower levels, which may further contribute to heparin resistance. So fighting an uphill battle there. This is TEG. It's essentially a computerized method to kind of assess your clotting, your platelets. It takes all of these things into account and tells you where you're at, if you're thrombotic, if you're hemorrhagic, and it's very, very complicated, but it's very interesting. I just wanted to throw a picture to increase everyone's heart rate this morning. So complications, we'll get into that. As we've talked extensively, there is bleeding, blood clots, coagulopathy, infection, limb ischemia, strokes, and seizures. Those are the big ones. This was a pretty interesting picture of a study done that looked at complications specifically and separated out based on what went wrong. So was it the cannula and you had a hemorrhage? 25% of patients in this population did. Was there a malfunction? And it compares neonate and child. Blood pump failure is pretty rare. Your membrane lung failure is another rare one. The circuit, that is not a rare one. If there's hemolysis within the circuit, again, with the neonatal patients, that's a much bigger issue, but it is an issue for everyone. And then patients with complications within the brain, that's another big one to think about, which we'll talk about, and that's hemorrhage, infarct, or seizure. And then, of course, the heart. Lung and abdomen. So essentially every single system in your body is going to be affected by this circuit, and all of them have a chance to have complications at varying rates. So the biggest, in my opinion at least, most important system to think about for long-term outcome is neurological, and it's of great interest in the pediatric ECMO community. Rates of neurological complication are higher in infants and children on VA ECMO as compared to VV. When you are cannulating a carotid, or if you have an aortic cannulation, this is not a benign thing. the change in cerebral blood flow itself, and cerebral vascular autoregulation during ECMO in the setting of being critically ill enough to require ECMO, needs sedative meds, etc., to decreasing the cerebral metabolism on ECMO support is a recipe for having issues in that department. And then, of course, exposure to foreign substances of the ECMO system itself is pro-inflammatory and pro-thrombotic, and this contributes to the illness process as well. So, wanted to put some data there. A systemic review of the literature of neurological outcomes following ECMO support in infants and children from 60 articles over a span of 16 years demonstrated that at hospital discharge, 48% of survivors had favorable outcome as defined by the pediatric cerebral performance category or unchanged from their original baseline. 48%, that is less than half. Long-term follow-up showed that 10 to 50% of children scored more than 2 standard deviations below the population mean on cognitive testing. 12% had evidence of severe motor impairment. 16 to 46% displayed behavioral issues. There's a wide range in disability rates because there's heterogeneity with reporting this, and underlying diagnosis, etc. And then varying age at follow-up as well. Overall neurological outcomes in especially neonates with CDH, congenital diaphragmatic hernia, cardiac disease, and we talked briefly about this cardiac arrest population, that's going to be worse. So if someone's arresting and you're coding them onto ECMO, their outcomes are typically going to be worse as expected. So this is just talking about neuromonitoring. I think this is fascinating, and it kind of separates it by age as well. So for neonatal, they had a group that indication was respiratory failure, and what they did for them was serial cranial ultrasounds while on ECMO, brain MRI before they were sent home, and then continuous EEG monitoring for at least 24 hours to monitor for seizures while they're on the circuit. You can't see if they're having seizures, of course, because they're sedated, they're paralyzed, and sometimes seizures are subclinical anyway. So you can't just look at your patient and be like, oh, they're seizing. Why are they seizing? Why would they be at increased risk for seizing? There's a lot of reasons for that. One of the biggest ones is intraventricular hemorrhage or some kind of insult. Pediatric, a head CT or brain MRI prior to discharge as well is recommended, and then continuous EEG for at least 24 hours. That can be reintroduced if other issues arise and you want to go ahead and see if they're having seizures again. And often this is on for a lot longer than 24 hours. And then cardiac failure. So again, this screening ultrasound, definitely more definitive neuroimaging, especially in the neonatal population if you're just doing the cranial ultrasound prior to discharge, and then continuous EEG again. All right, so implications for the general pediatrician. I thought that that last topic led really well into this topic because there's a huge role for our general pediatricians. So why is there a huge role? Well, you can see that ECMO is climbing. The use of ECMO is going up. And this chart is essentially showing that between 2005 and 2018, there's a huge increase in kids that are being cannulated for ECMO. Pediatric ECMO cases have increased 24% from 2009 and 2015, with a concurrent 55% in pediatric ECMO centers. Survival rates were approximately 61% for neonatal respiratory, pediatric respiratory, and pediatric cardiac ECMO cases, and then 42% in neonatal cardiac, as well as our peds patients who are coding onto ECMO. So still not terrible survival rates. So, for the general pediatrician, recovery is absolutely not complete until long, long after discharge. As we talked about before, these kids are going to be fighting against what they've gone through for a long time. In one study, they defined late death from ECMO as death greater than 90 days after coming off of ECMO. This occurred in 13 of 193 neonates, so 6.7%, and 10% children aged 28 days to 17 years. Late death after respiratory ECMO is more common with kiddos who have other underlying complications as well. So survivors of pediatric neonatal ECMO need identification and follow-up of neurodevelopmental impairment. So this is someone that you are going to see frequently. You're going to monitor their development throughout the next couple years at minimum, given the history that they had. The ELSO guidelines recognize this and explicitly call for ongoing care to help recovery after discharge. And then these recommendations are definitely aligned with parental preference, ranking functional status after being on ECMO as the most important outcome after survival. That makes sense, right? You want your child to have a good quality of life after being on this horrendous journey that was life or death. That's the next biggest thing. And parents receiving ECMO-specific follow-up after hospital discharge found it helpful in 95% of care. And they identified receiving reassurance, anticipatory guidance regarding long-term ECMO effects, and referral to specialists to address patient-specific needs as the most helpful elements of follow-up care. So this is why the role of the general pediatrician is critical in this situation. There are so many avenues that ECMO hits, whether it's neurodevelopmental, whether it's growth. These kids are going to be delayed in so many areas, given that they've gone through such a trial. And having that general pediatrician to organize where they need to go. Do they need to see speech? Do they need to see a dietitian? Do they need to go to GI? What do they need? And getting them there is critical, just as critical as being on the circuit in the first place. So I talked briefly about ELSO, the Extracorporeal Life Support Organization. This is an international nonprofit consortium of healthcare institutions, researchers, and industry partners. And their quote, "We provide support to those delivering extracorporeal life support through continuing education guidelines, original research publications, and a comprehensive registry of ECMO patient data." So if you go on their website, the picture that I have up here, this little screenshot, this is an active, ongoing poll. So you can go on, every single ECMO center is listed there, their level of excellence, which is what they're defined as based on the outcomes, the resources, et cetera, is on there, so they can have a bronze level, silver level, gold level. And all of that is public information that you can see. Every single ECMO case will be put into this. This is the total running right now since this was established. So you can see there's 199,246 ECMO runs that have been documented on this, with a 54% survival to discharge or transfer. And then it will also break down exactly what is in which department. So neonatal, we had 35,000 pulmonary, 10,000 cardiac, and ECPR 2,000, and that's when you code onto ECMO. Pediatric, there was a total of 36,000, so 12,000 pulmonary, 16,000 cardiac, and 6,700 of ECPR. So it has an ongoing running total. There's a ton of guidelines on there, tons of new research, support, et cetera, and it's definitely something that's integral to this whole process. These are my references, and I welcome any questions.
Dr. Keys says, are there any data in pediatrics, not neonatal, about outcomes, mortality, and ECMO versus conventional therapy?
So there is not a ton of data there yet. That's a process of ongoing research right now. They have the statistics of mortality, just like I had on the last slide, but nothing specific that would be super helpful.
Yes, I actually also wondered about the kids who are that sick but don't make it to echo and potentially recover, what their morbidities look like compared to the kids that were on ECMO.
Yeah.
I suspect they're not tremendously different. So
Yeah.
the slide of complications from ECMO with neurodevelopmental delay and things, I think we probably see very similar in the critically ill kids who don't make it to ECMO but do survive.
Yeah, no, that's a really good point, especially because it is such a huge decision. Like I had so many slides on just, are we going to cannulate them at all? Because that difference is marginal. So if they're going to have repeated barotrauma, if they're going to pop pneumothoraces over and over again, and their lungs are going to be on like over 60% FiO2, which can be huge for their lung development and overall. That's something to think about. But then you also have all the complications of bleeds and neurodevelopmental outcomes and et cetera. So it's a huge, like, are we going to do this? Is it worth it? And sometimes that contributes to the mortality rate as well, because they wait, like, rightfully until the very last second. And that can skew your data either way. So that's something that's a point of research right now, if we cannulate them earlier, because we can predict the trajectory of their illness. They are going to have all of these complications, and we're not going to wait and find out. Then is that going to be a better outcome for these kids getting cannulated early? So that's a huge point of discussion right now within ESLO and et cetera.
Dr. Brown, this is Dr. Mulliner, Andy Mulliner. Many of you probably don't know me, but I was at Carilion Children's for many years. That was an excellent review. Neonatal ECMO launched my career in pediatrics as a student at Virginia Tech in the mid-70s. I built and tested a neonatal ECMO system successfully in rabbits. And the pump we used had minimal hemolysis. It was a great system, just at the wrong time. We were developing it as the clinical trials in adults were being completed, and nobody was really interested in ECMO, but I went off to medical school intent on going into neonatology because of that experience. At that time, controls were a big issue, and now with microcontrollers and the incredible ability to control these systems, that's been great. A little lesson in health economics. When I was a fellow at UNC in the mid 80s, while Dr. Keys was doing his pediatric residency there, they shipped me off to the University of Michigan for training to lead the neonatal ECMO program at UNC Chapel Hill. And so after receiving all of this training and coming back, they did a cost analysis and in the end deferred to let's send our babies to Duke. It'll be a whole lot cheaper and we won't have to invest in a big program. So, it's just sometimes the economics, especially in pediatrics and pediatric devices, can really be a barrier to entry into some of these technologies. In the mid-2000s, a group from NASCAR, of all places, who had developed a hard carbon material for high-performance car engines, decided that they wanted to become more philanthropic. And we're looking around, and this particular material permitted the development of circuits for neonatal ECMO that did not require anticoagulants. And they were going down a pathway to developing a revolutionary system. But when they looked at the economics, they determined it would be a whole lot more advantageous economically to divert their attention to the preservation and transport of organs for transplant. So they switched from babies to kidneys, livers, and hearts. And but this is a phenomenal technology. We learned a lot with COVID about this, and I would encourage you and others to continue this kind of work. Thank you for your presentation.
Thank you so much. That was amazing. Very fascinating.
Dr. Muehliner, this is Chris Pierce. You should have been more persistent, and you would have joined the likes of Leo Arp with the ARP ventilator and gotten Roanoke on the map further.
Well,
None of them knows what the ARP ventilator is, though.
you know, that's another story about how physicians and others need to get along. And I had an advisor who was a genius in terms of development of devices, but fell flat on his face when communicating with physicians and others in the medical field. And he published his findings in the wrong journals. Lessons learned of what not to do. Yeah, Dr. Leon Arp, who passed away a couple of years ago, developed a ventilator that was probably 20 years ahead of its time. He was doing nasal mask ventilation, patient triggered in the 60s successfully. And his clinical trials were there at Roanoke Memorial Hospital with, and one of his collaborators was Dr. Doug Pierce. So you just never know where things will come from. Thank you.
Thank you.
Can you explain what ECMO lung is and like what support the lung receives when they're on ECMO?
Yeah. So that's a great question. I didn't get into it a ton because it's a whole other thing, but I'll talk pretty much specifically about what support the lung gets. You don't take them off of the ventilator most of the time. They're continued to be on it, but on extremely low settings. So the same kid that needed like a PIP of 40, which is huge, and had MAP or mean arterial or airway pressures like in the 40s as well, that's causing these pneumothoraces and long-term chronic changes in the lung, you would put them on minimal settings for airway clearance and just to keep the lung kind of functioning, so that you don't lose that tissue, so you don't lose the lung function overall. So you wouldn't put them, on the ECMO circuit and be like, well, the lungs can just totally chill. If you don't use it, you lose it. So they continue to keep them on very minimal settings, just so they continue to go to the practice. And that's actually how you get them decannulated. You will start to increase some of those settings and see how it's tolerated. And then if it is tolerated, then you will make start the process to decannulate them.
What kind of nutrition do people get when they're on ECMO?
Yeah, good question. So it depends on how sick they are. If they are at a center that's super comfortable and they're on VV ECMO and they're not on pressors and their gut is functioning, then they can get feeds in some places. Other times it might be a TPN situation because they are on pressors or they're on high levels of support and the gut is not going to get enough perfusion to be able to take that nutrition in. But that's a really good question. Thank you.
If there are no other questions, thank you, Dr. Brown, for an excellent presentation.